Hi, guys.
Hey, Kankan, flow team.
So I'm just curious, how many of you are still in training, like residents and fellows?
I'm actually, hey, this is Priya.
Hi.
Hey, I'm actually in 4th year right now, APCP.
Okay, you're going into IMPATH next?
Yeah.
Where are you going?
MD Anderson next year.
Oh, nice.
Yeah.
Congratulations.
Thank you.
How many fellows do they have? 6, right? They have 6?
We have 3 per year, so a total of 6.
Okay. Okay. Akanksha, are you there? It's like she's busy.
No, yeah, I was over here. I was talking all the time and on mute. I allowed you to.
Okay. Yeah, were you saying something?
I said I allowed you to share the screen, so you can start sharing the screen.
Can you see my screen now?
Yep.
Okay. So who's doing case 1 today?
No one. Let's see. We have to start calling names.
Well, if there are no trainee volunteers, I can take it.
Okay, you can
Yeah,
take
go
it.
ahead.
So let's start with this one. She has a peripheral blood tube and a bone marrow tube. So let's start with the peripheral blood tube because that's what we see first. Okay. It's just a different software, but it should be the same thing.
Mm-hmm. Okay. So peripheral blood, side scatter, forward scatter. I mean, there's a good percentage of granulocytes, which is expected, and then looking at the leukocytes with side scatter and CD45, lymphocytes comprise only 2.47, but there is a dim population, which is about 75.52%. And in the lymphocytes, only 2% is CD19 positive, which is not very significant. And they are polyclonal for kappa lambda. Yeah, strong 19 positive.
Why do you say they're polyclonal for kappa lambda?
Oops. I meant they are negative for both kappa lambda. I'm sorry.
Yeah, okay.
Yeah. So they're 19 positive, 5 negative, partially 20 positive, again 19 positive. Ten positive, strong positive. So they belong to the blast gate and they have 19, strong 19 and 10 with partial 20, which can be seen in the blast population at times. .38 appears to be partially positive. So if you're thinking in terms of B lymphoblast with this particular dim CD45 and 19 and 20, and they are negative for, I mean, they don't have surface light chain expression, that would be a good fit for B lymphoblast.
Okay. She has more tubes in the peripheral blood. Let's go to the T-cell tube.
So in the T-cell tube, they're clearly negative for, I mean, again, we are going with the blast gate, right?
Yeah.
So the blast gate and T-tube shows that the negative of 3 and 4, 8, 16, 56 negative, they're positive for 34. Again, in mature marker, negative for 5, 3, and partial CD2 positivity. So CD2 is a common aberrant antigen in all types of leukemias, acute leukemia specifically, especially, and 8, 4 negative, 56 negative. I'm not actually familiar with the last, that star-shaped, stellate-shaped plot. What does that show, actually?
They're trying to give like a three-dimensional demonstration, I think. We don't have that in ours either, but they're just showing that the population is only on the CD34 in this, of all these colors. How many we have? 1, 2, 3, 4, 5, 6, 7, 8. In the 8 colors, it is only positive for CD34 and it is negative for everything else. Is that the purpose, Akanksha, or is there any other purpose to this one? Okay, I think Akanksha is a little busy today.
Nahin, Arey, I am all the time on mute, and I say things and they kind of disappear. Yeah, that's the purpose of it. It just shows the three-dimensional picture, as you said. I tend to ignore that. It doesn't help me a lot. The other markers are the ones that I really look at.
Okay. All right, so we have a cytoplasmic MPO and a cytoplasmic TDT tube. So this is a cytoplasmic MPO tube.
Mm-hmm. Okay, and I see a similar pattern of colors here, and we see that the blast population is HLA-DR positive. So the granulocytes are in the green region. So basically the blasts are negative for cytoplasmic MPO, but positive for DR, CD123 partial.
Okay.
Yep, 50 negative.
Yeah, that's pretty much what they have in this tube.
Yep.
All right, and TT.
And cytoplasmic CD22, again, more supportive and favoring BALL with CD79A, additional marker. TDT positive. Yes, 19. Yeah, it's a very good example of BALL.
Okay. So then she has bone marrow, but I think that's
the same, actually.
Same thing. Right.
Yeah.
Okay. Okay. So I'll just briefly show, like you said, this is a classic case of BALL. So BALL blasts, they are in the blasts are usually in the blast gate. So they are here. The blast gate is usually below the granulocytes and they are to the left of the lymphocytes. The lymphocytes have the brightest CD45. They are dimmer than the lymphocytes. And these blasts do not have high site scatter. Like if you remember, lymphoblasts are usually like they don't have any cytoplasm, they are tight. And even the chromatin is a little bit more condensed than what we see in the classic myeloid blast. They are not that open. So, and they have less complexity in their nucleus, which is why we don't have a big site scatter in that population. And they are getting the mature lymphocytes in the red population, but probably there is some spillover from the blast into this gate, which is why There are some cells that are 19 positive. Again, they don't have any kappa lambda. So they are probably just blasts that there's a little bit contamination in that gate. So your blasts do not have any surface light chain, kappa negative, lambda negative, like what we expect. They are negative for 5. B lymphoblasts do not have any 5. And they have partial CD20, which is also very common with blasts. They can be either negative for 20, partial, but they are not bright homogeneously positive for 20. And they have really bright CD10. That is, again, the classic lymphoblastic marker, CD10. And in CD38 is usually positive or at least partially positive in BALLs. Very rarely they can be negative, but almost always they are positive. And yeah, that's pretty much it from this one. Then I think in MPO tube, you brought up a nice point that we have to compare the intensity of the granulocytes. So in this CD45 versus site scatter plot, we can see that the green cells are the granulocytes. They have the higher site scatter, and those are MPO positive, and the blasts do not have MPO positivity. We have to compare it with the internal control or the granulocytes that we have here. And these blasts are positive for HLA-DR, and B lymphoblasts are almost always positive for HLA-DR. And they have partial 123, which is very unusual. Usually 123 is positive on AML blasts, more in the monocytic lineage blasts, and they're also a specific marker for blastic plasmacytoid dendritic cell neoplasm. I haven't.
What did you say the first thing before monocytic? Which else is it?
AML,
Myeloid.
myeloid blast.
Monocytic
blast-
differentiation, right?
Yeah. More in the monocytic lineage blast, and also even other AMLs can have 123. In fact, when something expresses 123, we usually talk about it's more in the myeloid side, but I have not, this is my first time seeing 123 on a lymphoid population, in a lymphoid blast. That's kind of new to me. I have to read about that, but if anybody else has different experience, please share. But otherwise, this tube is pretty classic.
And HLA-DR, is it often this bright? And
Yes.
Okay.
It is often bright, yes.
Okay.
And so basically, you have to remember, you should have lineage specific marker. To call it a BALL, your lineage specific marker here is bright 19. It should not be like a partial 19, because you can have variable intensity of 19 even in some AMLs. So that's not enough. You should have a bright 19, and if 19 is not bright, then you need at least 2 other markers like 79A or PAX5, or even 10 is included in that list in the WHO. And loss of light chains help, but also you should have one immaturity marker like CD34 or TDT or CD99. If some people have CD99 in their tubes, one of these. Or if you don't have them, at least by IHC in your tissue, you should have an immaturity marker, because high-grade B-cell lymphomas can lose light chains, and they can have some of them can have CD10. So you definitely need an immaturity marker to make that distinction. So I mean, at this, I think it's appropriate to mention that even if you look at the WHO, the high-grade B-cell lymphomas are the double hit or triple hit lymphomas. They can lose light chain expression very often, and even in the book they say that if they are positive for TDT, even with double hit or triple hit, you should still call it lymphoblastic lymphoma and not double hit or triple hit. So that's why marker of immaturity changes the definition. So it is always important. You cannot call something BALL without that, and when you see it, you have to call it only BALL. Yeah, that's all. And CD2, like Priya said, CD2 can be positive on anything. AML, ALL, obviously TALL. So that doesn't make or break anything. And CD22, 2 things I have to mention here. One is CD19. CD19, we have targets these days. Does anyone know what we are using? Okay, so we have CAR T cells against CD19, and we also have this called blinatumomab. So when you see in the patient's chart for Blincyto or CAR T cell therapy, be very cautious because in first diagnosis all is fine, but when they are coming for a follow-up or day 28 or MRD assessment, CD19 may not always be helpful because these days they give CD19 a lot. Blinatumomab, it's also called a BiTE. Or bispecific T cell engager, short form is BiTE. It will actually use the patient's own T cells and bring it towards the blast. It has target for both CD3 and CD19. So it brings the T cells towards the blast and the T cells will destroy the B lymphoblast. So in our follow-up specimens, 19 alone may not be helpful. And also these days, if you see, every lab would add CD22 in their panel because CD22, we have targets again. It's inertizumab, it's a monoclonal antibody against CD22. And clinicians will often call you if you don't write in your report CD22 is positive or negative. And with my discussions with oncologists, they don't really care about the percentage of cells that are positive for CD22. They just care about positive or negative. So they want to know even if anything is positive. And if CD20 is positive, we need to say that it is positive. And some people feel it is better to mention how much of the blasts are positive, or some people say call it positive only if it is more than 20% of the blasts are positive, because that's what is the treatment criteria for rituximab if they want to use it. They don't use it in the first line, but in the future, if they want to use it, if more than 20% blasts express CD20, they can use it as per literature. So those are the three things you need to remember. So make sure, which is also why people use more than one tube for BALL, because they want to make sure they have all the phenotypic information in the diagnosis, so that if one or two of these markers get slammed in the follow-ups, they can use the other markers to detect the residual population.
And CD19 should be positive by IHC for the blinatumomab therapy. Is this correct? This is what I remember. Because the epitopes that are tested on flow and IHC are different, and IHC is the one that we need for the therapy.
I have no experience doing CD19 for IHC. I mean,
Yeah,
we had
send
IHC.
That's why we specifically used to send out CD19.
For 19 or 22?
CD19 IHC.
Are you sure it is 19, not 22?
Yes. I'm 100% sure it's 19.
Oh, okay. That is stored. No, we never did 19, and our patients get Blincyto left and right. We always did by flow, never by IHC.
Yeah, okay. we never do 19 by IHC. This is a news to me.
I have seen clinicians specifically ask for 22 by IHC when 22 is negative by flow. They sometimes, but that never came back positive either, because this is a cytoplasmic tube anyway. But 19, we never did that by IHC for this purpose.
I mean, this was from 2017-18, so it's possible that things have changed a bit now.
Okay.
And it's good that if the flow is accepted, I mean, that's very good, because that's more easily available.
Yeah, okay. Anybody else has any other comments?
And regarding 22, should it be cytoplasmic 22?
No, that's what they usually test, but not necessary.
For the therapy.
For the therapy?
Mm-hmm.
No, I don't think so. We had surface tube at Hopkins. That's okay.
Surface 22.
Yeah, okay. But when 22 is negative, the clinicians have asked us to send it to IHC sometimes.
Okay.
I've seen that happen, but 19, I've never seen that happen.
Okay.
Okay. Anybody else has anything else? Okay. Okay, case 2. Who's going to do that? Case 2 is more like a revision.
I think Pooja was going to do that. Is Pooja here?
Yeah, I'll do it.
Yeah.
Hello,
Okay.
can you hear me?
Yeah.
I'm sorry, although I looked at it very briefly, but I'll give it a try.
No problem.
So there are low side scattered dim to negative CD45 population, which is our blast, which is around 97%. And then these are positive for HLA-DR, also partial to good, like I'm not sure if we call brighted, but it is positive for CD34. And it is negative for 33, 117, CD38 is positive, and CD14 and 64 are negative. CD11B, there is like partial to negative, but there is like bulk of the population is negative, but there is a very minimal CD11B positivity. CD7 and 3 are negative, CD8 and 4 are negative, 19 and 10 are positive, CD20 is positive in around half of the population. And then we had cytoplasmic TTT, which was positive, and PO was negative. CD22 is also like partial positive, and CD9 is positive. So I was thinking of BALL.
Okay, so we'll discuss a few things here. So one thing is CD34 is partially positive. So this is where we use the word partial for this CD38. The way this CD38 is positive, the way this CD34 is positive, we'll say partial for these cases.
Okay.
And as you said, it's negative for all the myeloid markers. And 11B, we will consider this negative because it's really not positive going into that side. It's just that the population is too big that it's kind of spilling over, but it's not actually positive. And 20 is partially positive. That is correct. So this 22, we will call it negative.
Okay.
Although the quadrant is drawn this way, we would still call it negative. And CD9 is another interesting and useful marker for BALL. CD9,
this is just for prognosis, right? It's not for diagnosis.
I mean,
CD9.
right now we are not using it as such for prognosis. It is to differentiate between, it helps when you want to differentiate between neoplastic and normal B cell precursors. Not in cases like this where it is very obvious, but in follow-ups. So normal B cell precursors should have heterogeneous expression of CD9, somewhat like, your CD20. It should never be like this tight cluster. When you see this tight cluster, you should think about BALL. Like obviously this one has 97% blast, there is no question. But when you have like 2%, then that's where the problem comes to differentiate between hematogones and BALL. That's when markers like CD9, CD58, CD13, 33, all those are helpful. When you see a dense tight cluster in CD9 or expression of CD58, homogeneous expression of CD58, and expression of CD13 or 33, which are aberrant in a B cell precursor, all those will help you to distinguish between normal B cell precursors and hematogones. Also, we have to remember that in follow-up of B lymphoblasts, they are very susceptible to change their phenotype. The phenotype that you see in diagnosis does not have to be there when you follow up. Things change. They can become from TDT partial to TDT bright or even TDT negative. They will just become CD34 partial to CD34 bright. All sorts of things happen. And so, which is also why we have more and more markers in the B cell tube to help us distinguish between the neoplastic and the normal B cell precursors. And they always insist that never go by the diagnostic phenotype. If something is aberrant, call it neoplastic, not necessary that the original population should have had the same phenotype. Okay, any questions?
Top line, yeah. In the top line, do you go there like, is it a pre-BLL or like intermediate BLL? Or
Oh, no. No.
You never go that side.
No, no. We say 97% B lymphoblasts identified. That's it.
Okay.
Yeah. Precursor B. Actually, the term that the WHO book uses is B lymphoblastic leukemia lymphoma. That's what we use. We don't go into the nobody. I don't think anybody does that. If somebody has a different experience, please share. But we don't go into which stage of the B cell it is.
Yeah,
Sure.
we don't go there as well. Just B lymphoblastic leukemia lymphoma. That's it.
Okay, this one. I think this one somebody volunteered already, right?
This one, no one volunteered.
Case 3?
No one volunteered for this one.
I
But
can
maybe
This one.
Yeah, you can go ahead.
Yeah, somebody is saying they can try. Priya Nirmala Nathan, is that you?
Yeah, that's me. I can choose this one.
Yeah, sure. Go ahead.
So we see 58% blast population, which is CD34 positive, CD33 negative, and HLA-DR bright. The CD34 positive blast are also expressing bright CD13, and they're negative for CD11B. CD14 and CD64 are negative. The T-cell markers are also negative. So CD7, CD3, CD8, CD4, all negative. But CD19 B-cell marker is positive in addition to CD10. So we have immature B cell with positive TDT and negative for NPO. Also CD9 positive and CD22 positive.
Okay. So
So
one thing is CD33 is partially positive.
okay.
Yeah. Okay. So what do you think this is?
So BLL.
Huh? Sorry, I can't hear you.
Oh, BAL.
Yeah. So this is a BALL. The reason I had this in the teaching case is because this has a nice CD13 expression, homogeneous. 13 is a commonly accepted myeloid marker. We don't usually see that in lymphoid, not in this intensity. And this CD33 is partial, which is also nice to demonstrate. And yeah, that's pretty much what was different from the previous case. And you can see in MPO that the blasts are negative, the 19 positive population is separate here. So can you like guess what the cytogenetics would have been on this case? Just a wild guess. It doesn't have to be that, but there is a way to guess. Okay, so this was Philadelphia chromosome positive BALL. This is a 922. And CD25, they say, is the most reliable marker for predicting 922 positivity. But in our experience, all my colleagues also say the same, that this much of bright 13 and nice myeloid expression for 33, we see this often in 922 positive BALL. So that's a nice thing to kind of correlate. And we also sometimes get consults because 13 and 33 are positive. They want to rule out biphenotypic. But no, when you see this, 13 and 33 are not lineage specific marker for myeloid lineage. They are associated markers. They are commonly associated with myeloid leukemias, but they're not lineage specific. The lineage specific marker for myeloids is MPO. You can see in the MPO tube nicely that the blasts are negative for MPO, and there is no real separate population of blasts in the MPO either. So this is not biphenotypic or ambiguous lineage. This is just a BALL with aberrant expression of 13 and 33. Any
I have a
questions?
question. Yeah,
Yes.
the first tube, side scatter in 45, the blast population is kind of going up. Is it because it has some myeloid markers or kind of?
It doesn't have to be because of the myeloid marker, but this particular case, the blast had a little bit of extra cytoplasm. I'll try to pull the case later if you want to show the blast morphology, but it did have some cytoplasm, quite a bit of cytoplasm in those blasts.
I mean, the gating would have been like, how did you differentiate like where to stop this gate from the granular size? It's kind of very.
Oh, you see that just forget the colors for a minute, and if you just remove this red gate and this yellow gate, you see that this population is kind of clumped here, clustered here, and there is actually there may be a small space between the two populations.
Okay, got it.
Yeah, and in fact, this gate also includes a little bit of cells that are not blasts, which we can see here.
Yeah.
Yeah. I don't have 15 here. I mean, if I had 15, I would have shown that those are actually grants with 15 positivity.
Hi, this is Buthaina. I have a point to add. I also think that you mentioned like these are Philadelphia positive chromosome, right? So the blast usually, remember, they will have granules, like eosinophilic granules, chunk of granules. So this might explain the blast morphology. Probably, I am not sure.
Oh, in lymphoblasts, I mean, lymphoblasts can have granules rarely, but it's not very common to have granules in lymphoblasts. To an extent to have side scatter. I don't remember seeing granules in this one. There was a lot of variability in the size. It had both smaller, medium, large size blasts, but I didn't remember seeing granules. It had cytoplasm, but I didn't see granules.
I just like, okay.
Yeah, I mean, it is possible for some lymphoblasts to have granules. Even you can see odd rods in lymphoblasts as per textbook. I've never seen one though, but people say that it can happen. But in this particular case, I did not see, but that's a good thing to think about when you see that. Any other questions or comments? Okay, case 4.
Hi, I have a question.
Yeah.
So here in each plot is square shape. So on the side, they show some percentages like 33, 55 for these. So what's they means? I mean that during processing, they're showing the percentage of these cells.
So when you see in the CD45 versus side scatter, you see these colored grades, right? So red is one population, blue is one population, green is one population, orange is one population, and you have percentages along with them. So that means this is the total viable cells that we see in this plot, and among the total viable cells, 58% are blast. So now we are only taking the 58% blast, and we are putting them in these templates. So we are analyzing this blast only the blast population for 34 and 33, and in that 58% of population, 33% are positive for 34 only. 55% are positive for both 34 and 33. That's what it means.
Oh, okay. Oh, that's why you said this plot that partially positive CD34. Even it's showing like very upper part of the. So okay, now I understand.
No, this one is fully positive for CD34. It is only partially positive for CD33.
Okay.
CD34 is like normal positive.
Okay.
Homogeneous positive, yeah.
Okay.
And this population that is here, it's just contamination. It's not the blast. It's just in the gate. Something from the granulocytes that had creeped into it, but it's not. Those are not blasts.
Okay. Thank you so much.
No problem. Okay. This one we have someone, right?
Yeah, I think Pooja, no, Priya was going to do it.
I saw a few Priyas.
Yeah, there are 2 Priyas here.
Okay.
Okay, so here we see low to dim CD45 low side scatter for the blast 92%. The blast are CD34 positive with CD33 expression as well. Occasionally DR bright, CD117 negative. The blast are CD13 negative, CD38 negative, 1117 negative, CD64, CD11B are negative. So I think that these are the monocytic markers are not being expressed by the blast. And CD7, CD3 negative. And then so the T cell markers are also negative with CD19 expression, CD20 and CD10 are negative, or with partial expression of CD20. And TDT is positive, MPO is negative. CD34 blasts are expressing the CD19 and CD22 and CD9 partial positivity. So again, I think this is a BALL.
So what is unusual about this case?
The CD20.
Can you be a little bit louder?
Can you not hear me? CD20?
CD20? Is that what you said? No.
I think it's CD10 negative, which can happen, but it's like an example, like which is 19 positive and then 10 negative.
Right. Yeah. So CD19 positive, 10 negative. It's very BALL, classic BALL will be like bright 19 and 10 positive, which is why in many places they will just have those two markers in their screening tubes to isolate the population. But this one is 10 negative. And do you know any cytogenetic abnormality that would be commonly associated with this?
11q is usually 10 negative, 19 positive. 11q rearrangement.
11q or
Right.
MLL.
Yeah, MLL or KMT2A. Yeah, exactly. That's what this case was. It had an MLL rearrangement. Okay, but otherwise pretty much the same as what we discussed. Any questions or comments? Okay, then we'll
What
go to
was the
this.
genetic abnormality you said?
KMT2A rearrangement, BALL with KMT2A rearrangement. It's an entity in WHO under BALLs. So those cases often have 10 negative.
I see.
By
Thank
IU,
you.
by
Thank you. Thank
no
you.
problem. This one.
Okay, so I can try this one.
Okay.
So again, so we see that navy blue is within the blast population. And so if we follow that, the blast population is CD19 positive. It is not kappa or lambda restricted, so it's not expressing light chains. It is CD19 positive, CD5 negative, CD38 positive, CD10 positive. It's also expressing CD200, CD19, and again, CD20 and 10 is positive. And here, so CD30.
This is another tube.
Okay, so this is, so we see CD34 expression, which are not expressing CD3. They are expressing CD10. They are negative for CD2, CD7, CD4, mostly negative, and CD8.
Okay.
The aqua here is within the blast gate. It's bright HLA-DR, CD34 positive, CD-HLA-DR positive blast, which are not expressing CD117. Yeah, it's not expressing 117. So I see just repetitive things here. CD34 positive, HLA-DR bright, 10 positive, 13. CD13 is partial.
Okay.
And then CD33 is also positive or dim. So the blasts are expressing 22, and they are MPO positive.
Huh?
Wait. No, MPO negative. MPO negative.
Okay.
So, so I think it is a lymphoblastic lymphoma.
Okay, anybody want to add anything or any other comments before I discuss?
I think it was 13 and 33 positive, and those 9, like the Philadelphia positive BLLs are they express that here in this part. Okay, 13 is there, and 33 may
This is
not be
the
there.
side scatter versus CD34 if you want your reference population.
So yeah, 33 then is negative. I think 13 was some. There is some. Maybe both are negative then. Yeah, because like background lymphs, they are falling where? So maybe negative then. Yeah.
Where are the background lymphs in this one?
Sorry.
Okay, let's
Wait.
okay. Okay.
Yeah,
Anything
maybe
else?
I'm confused.
Anything else abnormal, or anybody else has anything else to add? Not in this tube, but every other tube.
CD 200.
Okay, CD200 is positive. CD200 can be positive in BLAS. Both AML and BALL BLAS can be CD200 positive. That's a good observation. Anything else? Okay, so this plot, we are all clear that there is a population here that is dim for CD45, positive for 19, no surface light chain, nicely 10 positive, partial 38, 200 positive, partial heterogeneous 20, good, satisfied. We'll come to this later because I think I forgot to put the CD45 in side scatter. Anyways, this one, you see this aqua population, okay, but you also see a blue population, this one, hiding behind the aqua. And if you track this dark blue population, that is also positive for HLA-DR. The only difference is the dark blue population does not have CD34. It is negative for CD34, and this is positive for CD34. And both populations don't have CD117, but there is a clear distinction between the two populations. And again, in this tube, we see that the dark red are the lymphocytes. These are the granulocytes. And here also we see two colors, blue and brown. And if we track, the brown population is positive for 34, blue is negative for 34. We have your granulocytes here and monocytes here. And we have both populations are positive for CD10, both are positive for HLA-DR. And the brown population is positive for CD13, and the brown population is positive for CD33 because these are your granulocytes. This is monocytes. Monocytes have the brightest CD33. We have to compare the expression. We don't expect the BALLs to have that intensity of CD33. You can compare it to the neutrophils or the granulocytes for the decent expression of CD33. We see at least a subset has the same intensity of expression of CD33. And this CD34 positive blasts also have partial CD13 expression. So that's the reason they did this MPO tube, to make sure the CD34 positive blasts are not something else, but just a subclone of the BALL population. So we see that in this, the CD34 positive blasts do not express MPO, and this is our reference gate, CD45 versus side scatter. We have granulocytes here, and the blasts are sitting here. We have two different colors. The reason is because they saw that a subset expresses CD22 and the CD22 expressing blasts are painted in green. So whatever is negative for CD22 still has this blue color, but all the blasts in general, they have it in blue. So the CD34 positive subset do not express MPO. That's basically what they are trying to see here. And this is the other population of blasts, the dark blue. That is the reason why they did this MPO. Just to make sure that the
What is that blue population here in this plot, the lower one, like which is 34 negative? And
that is the other clone that is here. That is also a BALL clone. It is positive for, both are BALL clones. It's just that there is one population of BALL that is positive for CD34, and that population also expresses partial 13 and 33. So both this and this are CD34 positive. Sorry, BALL clones.
Okay. Is it showing in the above plots too, like, or it just?
Yes, in all the plots we have 2 clones. This is a T-cell tube, and even in this tube, I showed this one because you will see there are 2 populations that have dimmer CD45. Like this is not side scatter. This is dim CD45, right? CD45 versus 34. So you have to just see what is expressing dim CD45 in this plot. So you'll see there are 2 populations parallelly, which are dim CD45. And these are the bright lymphocytes. And then one population is positive for 34, the other one is not. Both populations are negative for CD3. They're both bright for CD10. Otherwise, there is no difference. Basically, the difference was that one population expressed CD34 and was kind of distinct. And that population also expressed 13 and 33 along with 19 and 10, which is also why they wanted to make sure it doesn't express MPO.
This blue population here is expressing 117.
No, it's not. It's not. Which is also why I gave this plot here, because your red here is the lymphocytes. So the lymphocytes express same amount of 117, just for so that you have the reference. So both the blue population, aqua population, they have the same intensity of 117 as the red population. So this 117 basically is like very noisy. So it should be here to be positive.
Okay.
Any questions? So you will see something like this. Sometimes you will see a subset that is having the same phenotype as the main clone, but that will have a little bit of different phenotype. That could be a separate clone, but the same BALL. So it's always better to make sure you evaluate that clone thoroughly before you release your report to make sure there is no biphenotypic or ambiguous lineage hiding in there before you release it. That's the reason I kept this case. Any other questions?
Yeah, thanks for including this one.
Sorry?
Thanks for including this one, that case. And how would you report?
So we will report the top line still would be the total number of blasts. I don't know, let's assume the total number of blasts in this one is like 30%, assuming 30% B lymphoblasts identified. And then when we describe the phenotype, we'll say a subset expresses CD34, 13, and 33. And we'll say we'll describe both the subsets.
Okay.
Yeah. Because it is possible that one of this is resistant to treatment. And when we follow it up in the future, it would be very helpful to document that.
Correct.
And another point is that sometimes one of the subsets, they go off and the other subset are present in the MRD. So that's something to remember too.
Yeah, so it's important to mention in the report. Correct.
Yeah, just important to mention. The MRD might be of a subset that is CD34 negative, for example, here.
Okay, Shweta?
Yeah, so on this one, we have a population of blast, which is kind of 3%, which I see like is variable from dim to moderate 45, low on side scatter. When we see it on the 33 versus 34, there is subset which is positive for 34, negative for 33, 117 negative, subset positive for HLA-DR bright, and again it's the same 117 and 33 negative in that population. On this one, again, it's bright on HLA-DR and 15 negative. 38 is moderate, I would say. And then 15 negative, 34 negative, 11B negative. It's very discrete population on 19 and 10 plot, which is like bright on 10 and moderate on 19, which is good. And then it is 20 negative. So that's that. And then this is the, on this one, I think it's 19 positive, 22 negative, and again, 19 positive, 34. I would call this negative. I think that's just a spray.
Okay.
22 negative, TTT. There is little bit TDT. I'm not sure that's a spray or something because the population is way separate from this. So maybe a small subset TDT positive, or maybe the next tube is more cleaner and sorry. I mean, there might be some subset which is TDT positive. I would say that.
Okay.
So and then where are we? Okay, then on this one, mature markers are negative, 20 negative, kappa surface, lambda negative. So this is basically the lymphocyte gate that we are looking in that one. It's, I think it's not showing up there in kappa versus lambda tube. I mean, it's a BALL. So yeah, that's where I was on it.
Okay, so, all right, so this is where it gets tricky. We have to see how this population is going and how distinct it is from the lymphocytes. These are hematogones, and I know you're calling them as a BALL based on the 20 negativity. And I think I also briefly discussed the other day that the tech forgot to put CD20, but actually we found out later that the tech put the CD20, but the patient is on rituximab. This was a AML patient who was post-transplant, and we thought there is no reason for the patient to get rituximab, but then we found out that the patient also has an outside rheumatologist who gives the patient rituximab for some autoimmune disorder, which we later found out. So that's what this is, which is also why I gave the B-cell tube, because you see some things that are positive for CD19 here, but absolutely no CD20, even on the cells that are expressing kappa and lambda, which is unusual. I know that is like a very minute population, but also when patient gets rituximab, you don't see normal B cells either. So it's very hard to trace them. So the clue that this is a hematogone is like when you look at this, you will see actually that, okay, you know what? I'm going to stop sharing for 1 second and I'll start sharing again. Because I want to show you the raw plots because it's not that clear here. Hold on, I almost found it. It's just taking its sweet time to open.
Rajeshwari, in the meantime, can I ask you one question?
Yeah, sure. Go ahead.
Like when patients are given treatment, how do you kind of have a prognostic markers here? How would the scenario differ when the patient is, whether the patient is responding to treatment or resistant to treatment, or, you know, how do we assess that? Do we have any plots like that?
I'm not understanding your question correctly. So you're asking, like after the patient was diagnosed with the BALL,
when they are given treatment, and then following treatment, do you also do the flow to see how well they are responding to the treatment?
So that's the thing. Like usually you get a day 28 bone marrow for that is when they diagnose, and then the next bone marrow that we get is day 28. Some people do day 14 very rarely, but on day 28 you're not expected to see any blasts. It's like the end of induction, and it should be already regenerating with no blasts at day 28. So if you still see blasts on day 28, then we call it resistant to treatment or persistent leukemia, and they will re-induce the patient or change that chemotherapy. And sometimes they do an assessment on day 14 to see if the blast count has decreased. But I didn't specifically save any of those cases.
I see.
But usually it is negative, and they will send it out for MRD, and we don't do MRD here.
I see.
So I don't have it.
Thank you. Thank you very much.
No problem.
Dr. Iqbal, do you know what is MRD? So MRD is a minimal residual disease, and that's that's a specific like the MRD is present in specific institutions, and I would say many institutions throughout the US, even in the US, they don't have MRD.
I see.
Yeah, like MD Anderson, MSK, these institutions, they do MRD, but many do not.
I see. And based on that, again, the treatment either continues or the treatment changes, right?
That's correct. Yes.
Okay, good. Thank you.
Okay, I'm going to share my screen again. You can see it.
And MRD is also done by PCR.
Yeah, that's correct.
Other than flow cytometry.
You can see your screen, Raji.
Okay, so in this, I'm going to even move this lymphocyte gate, all these gates away so that you can see them clearly. You see that in a blast, you will always see one homogeneous population in this area, CD45 versus site scatter, but here you see different populations. Like this looks like one population, this looks like another population, this looks like another population, and this looks like another population, and they are all in one, one stream. Like they're if I have to say, they go from here all the way to there. So now let's put the gates back, and so you will see different stages in hematogones, right? Early hematogones, intermediate hematogones, and late hematogones. When you see CD38, also you see that there is a population that is bright for CD38, and then there is a population dim for the CD38, because they are kind of losing their CD38 as they mature. Same way in HLA-DR, you have one population that is bright, one population that is dim. And again, in CD34, only a small subset is positive because the early hematogones are the ones that are positive for CD34. The intermediate hematogones, always we will see a bulge in the intermediate hematogones. That is what we will see the more commonly in our smears or in flow. And those usually have already lost CD34 and they are acquired CD10, and they are in the process of acquiring CD20. Just because the patient does not have rituximab, the patient has rituximab, we are not able to see the CD20 expression, but we can see everything else. So in these cases, you usually get help from, so we already saw this, how it is nicely positive for 19 and negative for 20. We usually get help from the immaturity markers tube, and you will see that other than that one small population that was positive for 34, which is also positive for TDT here, the majority of the cells that you saw in the CD19 and 10 gate is negative for all the immaturity markers, like TDT or CD34. So that's how we are saying that this is actually, and you understand what I'm saying? Yeah, that's all. I ran out of points. That's how we are distinguishing them.
And what is the CD9 positive? Oh, where did it go? You're just showing.
CD9, you will see like it's kind of variably positive. It is positive, but it's not like very tight. It's not clustering together. It's more like a heterogeneous population.
Okay.
Sorry, for CD9, does it like mark the immature hematogones or the more like maturing ones?
CD9 is positive on the immature ones. It is also positive on the intermediate hematogones.
I see.
I think it is expressed in all stages of immaturity. I don't think there is
Oh, okay.
Yeah,
because this is for me as a new, so I don't know. Thank you.
Yeah. Any other questions, guys?
When you label the tube on the top as myeloid bone marrow blast, like is it like the antibodies or you're adding to it? Like
but this particular tube has it's a B myeloid. B myeloid. It's the name of the tube that we give it in our lab because it has this one can differentiate between if there is two populations. For example, biphenotypic with B and myeloid, we can differentiate this one because it has both cytoplasmic MPO 19, 22, TDT 34, 9, all those markers necessary to differentiate the two populations. So it is also one tube that has 22. So anytime we see a BALL, we add this one.
Okay, got it.
Yeah, that's all. It's just like how we name it here. But otherwise, nothing other than what I said. Okay. We good? Anybody wants to say anything else?
I wanted to ask Shweta if she is in trauma.
No, actually, when you start from the end and you think the topic has to be BLL, you just like, and I was rushing today. So,
But it is also, I won't blame Shweta because this picture does not also clearly show it.
Yeah.
I thought it was quite discreet here. Like when you showed the population in the other like ungated plot, there it looked more scattered, and here it looked more concrete. And then I saw like few of the cells were like following the protocol, and I was like, okay.
Yeah. And that was a hard case. Like this one, 7 is rather easier than the 6th one, actually.
Well, I'm glad I did that. I make mistake, I'll never repeat it.
Right. Yeah, now you will see how it is in each plot, so make sure that it's not. Shweta, this one?
Yeah, this is the last one, right?
Yeah.
Okay, yeah. This one I was thinking of hematogens.
Right. So you basically see the same pattern in this one.
Same pattern. And this one I called it hematogens because I realized so much on that 1910 and that 2010 tube. But now I realize we always have to be cautious. Like, don't go by that all the time.
Yeah, so, I mean, it's very, very rare to have such a situation. Even this is my first time where a patient was on rituximab in this kind of a scenario. But it might happen.
Okay, yeah. This one has like 1022. This has a a waterfall or a
very classic. Right.
Very classic. Right. So this looked like hematogens to me, and I was like, okay, but that one 20 fooled me.
So people who for people who are new, it looks exactly the same like the previous one. You see a population that is having a dim CD45 and a very low side scatter, lower than the blast. It will be like lying low, even below the blast gate. And you would always see a continuum with the lymphocyte gate in this one. There may be a small nick between the two, but in fact, you will see like there is something very close to the lymphocytes in this one. And you might see a little bit of the population that are CD34 positive because your early hematogens are CD34 and 38 positive. And then as they acquire CD10, they will lose CD34. But on all stages, they are CD19 positive, that's the BNS. So here you see that they are HLA-DR positive, and even in HLA-DR, you can actually maybe see two populations that actually nicely shows in 33 for some reason, I don't know. And in 38, again, you see two populations, one with brighter and one with less CD38. And then in this plot, CD19 versus 10 is always dense because your intermediate hematogens are the bulk of the population, and they are all 10 positive and they are all 19 positive. So they will be tightly clustered there. So don't be scared about that. Use your 20, and in your 20, you can see like how cells that are losing CD10 and acquiring CD10 are present here. So this is your early hematogens here that are 10 bright, and those are the ones that will be 34 positive, and then they will start losing 10. This is our intermediate hematogens. They're starting to lose 10 and they're acquiring CD20, and these are late stage where they are acquiring CD20. And actually they say that once they start acquiring CD20, there are no more hematogens. They are, mature B cells. But I mean, these are like probably in the maturation, almost mature B cells with bright CD20. All right. Any questions?
Very cool cases.
Yeah.
So I wanted to tell about agenda for Saturday and Sunday. I guess we are done for now, right, Raji?
Yeah, we're done for now.
So I wanted to talk about agenda for Saturday and Sunday. Saturday, Sunday, we are not going to have any cases. We are going to read theory, because before starting with T, we should, at least for the beginners, we should know what we are expecting, and how the aberrancies in the T manifest. So we are going to read the T usual, like the antigen expressions, and then gating, and then we are going to read the Brentwood chapters for the T for the weekend. And once we are done preparing for T, then we are going to dive into the cases and start discussing the cases. Does that sound like a plan?
Yes, thank you. Very good.
Okay. I guess we can end here. I mean, we could have read a little bit of B lymphoblastic leukemia from Brentwood or from ACE boards, but since it is 5:05 already, I think we can stop here, and maybe we can try to cover like 10-15 minutes initially tomorrow and day after tomorrow, whatever we do, so we can try to cover that a little bit. All right. Thank you very much for the great
Thank you.
cases.
Thank you.
Thank
Thank
you.
you. Thank you, Rajeshwari.
Thank you. Thank you.
Bye-bye.
Thank you.
Bye-bye.
All right. Yeah. Bye-bye.
Thank you, Akash.
Bye.
Take
Yeah.
care. Bye-bye.
Yeah.
I have a question regarding
Yeah.
what we are preparing from. Is it on is it on the shared drive? I'm sorry, I'm new. I'm not sure.
Yeah. That's right. You just joined, right? So it is in the shared drive. All of these. So if you go into the group, in the WhatsApp group, if you see the group description, I have written the flow course materials. So when you navigate through flow course materials, you will see that the daily course materials are there. So these are all cases we put in the flow course material and whatever we have. And we do have a schedule, kind of, we are trying to follow the schedule, but not tightly, because we are following the sequence of the schedule, but not the days particularly. But the sequence is going to remain the same.
Right. Yeah, thank you very much. That's really great.
All right. Thank you. Bye-bye.
Bye.